These are some of the most common chromosomal abnormalities that we will discuss in the following slides. The first is Down syndrome, which represents the most common pattern of malformation. The most common way to have a baby born with Down syndrome is with non-disjunction during maternal meiosis during that pregnancy. And you'll recall that that's a random event and is associated with advancing maternal age. This gives us full trisomy 21, that is 321 chromosomes that are clearly visible on karyotype. However, remember that an alternate way to obtain Down syndrome, or any trisomy for that matter, is from a translocation. These represent an overall small number of cases, as you can see by the statistics. The vast majority of translocations, which a geneticist can read on a karyotype, are new mutations. However, in a small number of all translocations, the parent may be a silent carrier. That is, a parent, mother or father, is carrying the translocation, and depending on whether or not the baby gets that particular chromosome of the two, the baby then will still have 3 copies of the 21 chromosome. So it is imperative, once we have a child with Down syndrome with the features you can see in this picture, primarily the upslanting palpebral fissures, if then we have a karyotype consistent with translocation as to the method of producing this Down syndrome child, then the next step in management first has got to be to do a karyotype on each of the parents to see if they are a silent translocation carrier, because this has implications in terms of genetic counseling. If we look at younger women with non-disjunction, then there is a 1% chance, 1 to 2% chance, let's say, of having next child with Down syndrome. In other words, it's felt to be relatively negligible. However, for translocation overall, including all cases of new mutation, plus cases where the parent is the silent carrier, we have a 5-time greater chance of having a child with Down syndrome on a subsequent pregnancy, and this is obviously important for genetic counseling. Plus, it's important to identify other members on the side of the family where either the mother or the father had the translocation, to identify possible translocation carriage in them, especially for those who are childbearing age. This table lists the most common findings in Down syndrome. Again, by far, the largest and the most identifiable feature are upward palpebral fissures. Also within the eyes, we may have individual condensation of pigmented areas, and you can just see this somewhat in this child's left eye, the right as you're looking at it. These are called brush-filled spots. In general, all these infants at birth, and to some degree throughout their life, have hypotonia. Hypotonia, for the most part, gets better over time. On the other side of the table, we have epicanthal folds on the medial canthus, and you can just see them. They're very mild in this child. Keep in mind, however, that epicanthal folds are not specific to Down syndrome. In normal children, epicanthal folds gradually recess over the first year of life. Also, a single palmar crease may be seen, and this again is not specific to Down syndrome. People without any problems may have a single palmar crease. The rest of the findings are all sequelae to having Down syndrome, that is, morbidities primarily. Most morbidities occur in Down syndrome with respect to the heart. The vast majority of children with Down syndrome will have some form of heart disease, that is well over 50%, and therefore, when we make the diagnosis of Down syndrome at birth, we do get an echocardiogram automatically. Listed are, in order, the types of congenital heart disease that are most common with Down syndrome. Endocardial cushion defect is the most common. Next, they may have an instability at the atlantoaxial joint, where the skull and the neck join, essentially. And this is because of hypotonia and ligamental laxity, and may cause a sudden neurological devastating defect. And so this is often screened for early in life. Increased risk over the early years of life, particularly of the development of acute lymphoblastic leukemia occurrence at Down syndrome. These kids often have congenital hypothyroidism. They have hearing loss, which is both sensorineural to some extent, but mostly conductive because of the large increase in numbers of recurrent ear infections due to craniofacial anomalies. There are a number of intrinsic GI defects. The most common is with duodenal atresia. Secondly, Hirschsprung disease. And part and parcel, again, of the finding of Down syndrome is, some degree at least, mild, moderate to severe of mental retardation. And time into early childhood will determine what type of mental retardation and how functional these children will become as they get older. The four main features with respect to natural history of Down syndrome is early death due to any one of a number of problems, but most commonly with respect to heart disease. As stated previously, muscle tone gradually improves with age, but there's almost always some degree of hypotonia. The rate of development slows with age, and we now know that there's an earlier onset of Alzheimer's disease in adults. Edwards syndrome is the second most common. This is trisomy 18, again diagnosable karyotype, again related to older maternal age in terms of incidence, and the vast majority of these fetuses are spontaneous abortions. The ones that survive birth typically die in the neonatal period, and the vast majority of the remaining would not survive the first year of life. Mental retardation in Edwards syndrome and neurological deficits of various types are profound. These patients, as usual, have intrauterine growth restriction, which means that brain growth is slow, so they will have microcephaly, often with a prominent occiput. Characteristically, they have a clenched hand with overlapping fingers, a short sternum, rocker bottom feet, abdominal wall defects, particularly an omphalocele, and multiple cardiac defects again, the left to right shunts being the most common, but almost any form of cyanotic heart disease is possible as well. The third of the trisomies that we will talk about is Patau syndrome, which is trisomy 13. Again, most commonly non-disjunction. Karyotype shows 3 individual chromosomes at the 13th position, and once again, the incidence increases with advancing maternal age. These babies, again, have IUGR, symmetric, because of the fact that this is a chromosomal defect, which means, again, there will be a small brain, microcephaly. But characteristically, they have a very common type of brain anomaly, which is called holoprosencephaly. There are many other CNS defects. They will have severe mental retardation and neurological defects. Characteristic here are severe midline clefts, that is, severe cleft lip, palate, or both. They have a characteristic scalp defect in the posterior hair whorl called cutis aplasia. This is a round absence of skin with surrounding inflammation and alopecia. Here, with respect to the hands, while the fingers may be clenched, there's less overlapping of the fingers compared to what we see in trisomy 18, and most commonly we have what's called post-axial polydactyly, an extra digit, part of a digit, or a bifid fifth digit at the fifth digit, in other words, at the end of the hand or foot axis. Cardiac anomalies, again, mostly include septal defects, but can be any complex heart disease, and also very commonly in these patients we see a single umbilical artery. The Aniridia-Wilms tumor association was discussed in Chapter 1 on neonatology, and recall that the main association here is the Wagger association, W-A-G-R, which again stands for the random association of the findings of the development of Wilms tumor, aniridia, genitourinary anomaly, and retardation of growth and or development. And specifically, this is due to a deletion of 11p13. Also recall that one doesn't have to have the chromosomal anomaly. The infant can be born with just isolated aniridia, which leads to a higher chance of getting Wilms tumor, or you could have any one of a number of GU anomalies, which leads to a higher chance of getting Wilms tumor. But if the Wagger association is found, if the deletion is found, then this would represent the highest association with the possible development of Wilms tumor over the first 5 years of life. Klinefelter syndrome, which we see in phenotypic males, has a genotype of XXY. In other words, the extra X chromosome gives some degree of femaleness with respect to a couple of the findings. These kids, which most often are diagnosed later childhood and the beginning of adolescence, particularly when they're going through puberty, often have mild mental retardation, but most importantly, they have behavioral problems, which can be significant. Aggressive behavior, oppositional defiant behavior. There's a high incidence of fire starting in these kids. They are classically recognized by their phenotype, which is going to look very much like Marfan syndrome. In other words, they will have a Marfanoid phenotype, but then they won't have the other very specific findings of Marfan syndrome. And these kids are all boys, and Marfan syndrome, of course, can be boys or girls. So they're tall. They're typically greater than the 95th, 97th percentile for age. They have long limbs. That is, they're tall because their legs primarily are long, which means that when we compare their upper segment to lower segment ratio, the upper part of the body, which is defined as the distance from the occiput of the head to the pubic symphysis, is the upper segment, the lower segment from the pubic symphysis to the floor. Because their legs are longer, because the denominator is increased, that means their upper to lower segment ratio will be decreased, and specifically it will be less than 1. Finally, part of the phenotype is long arms and fingers, so that when we ask the patient to stretch their arms out to the side and measure from the middle finger of one arm all the way down the arm across the chest to the middle finger of the other arm, we will find that they have long arm spans. And the reason you determine that is long is that their arm spans will be greater than the height. This is not a normal finding in a normal person. The arm span should be no greater, usually slightly less than the height. The gonadotropic axis is abnormal in these kids. They typically will develop gynecomastia to some degree, as you can see in the slide, but they also have external hypogenitalism, and this is due to a decreased output of male hormones because androgens, and such as testosterone, are decreased, and there is nothing wrong with the pituitary gonadic axis. Then in these patients, follicle-stimulating hormone and luteinizing hormone will be increased, and we have the condition of what is called hypergonadotropic hypogonadism. And because of this, they pretty much, except in the rare reported instance, are not fertile, they have decreased sperm production, and they will not have children. The pure form of Turner syndrome would be the most common case where all of the cells are missing an X chromosome, which is most likely to be paternal in origin. And so we have XO, but phenotypically they certainly look like girls. This is sporadic and is not associated with older maternal age. The key features are that we have what appears to be a female who is short. Very short, in fact. If we do the comparison of the patient with the normal childhood growth curves, these girls will always be less than the 3rd percentile. The main endocrinological feature of this, because of XO, is gonadal dysgenesis, producing basically streak ovaries, essentially no ovaries and therefore no ovarian output. Keep one other thing in mind, that there are a number of cases of mosaicism, and we can have any kind of combination of X and even Y chromatin material within the cells, and this all needs to be identified at the time that the diagnosis is made. Particularly, the gonads have to be looked at because if there is Y chromatin, we may have some combination of some ovarian and some testicular gonadal tissue. This is called mixed gonadal dysgenesis, and the current rule is to remove those gonads because of the eventual risk of the development of a gonadoblastoma. The most common physical findings, which sometimes may be present at birth, but will be present in an older child with this, are lymphedema, because the lymphatics are always abnormal, and this will be present in the newborn period, so congenital lymphedema. The appearance of wide-spaced nipples because of a broad chest, what we call a shield chest. A number of problems with the posterior neck. Webbing of the neck, redundant folds of skin, abnormalities in the posterior hairline, and even the most common tumor, which we see in Turner syndrome, which is a cystic hygroma. There are a number of renal defects present in patients with Turner syndrome. In fact, kidney disease is very common. The most common is horseshoe kidney. There's a high incidence of all types of autoimmune disease, particularly Hashimoto's thyroiditis. That would be number 1. Number 2 is celiac disease, and we typically screen carefully for these with any possible onset of these two diseases. Now, most people usually think of coarctation of the aorta as being the most common cardiac problem with Turner syndrome. However, that isn't true. The most common cardiac abnormality is a congenital bicuspid aortic valve, and then coarctation. In fact, the most common presentation is a bicuspid aortic valve with the development of coarctation. Now, the bicuspid aortic valve, if it's going to be clinically significant, will present with early onset or congenital aortic stenosis. This usually doesn't occur, so the bicuspid aortic valve, if it's going to produce problems, will do so later in life in conjunction with the development of atherosclerosis, whereas coarctation is going to give the patient symptoms early on, and we will discuss those findings later in cardiology. Because of the abnormal pituitary gonadal axis, Once again, we have little female hormone output, estrogens, and that means that the follicle stimulating hormone and luteinizing hormone, which are produced normally, will be increased. So just as in Klinefelter syndrome in the male, the same issue results in the female with Turner syndrome, and that is hypergonadotropic hypogonadism. As such, when these patients are ready to go through puberty, which they will not do so normally, they need hormonal help with a combination of estrogens and progesterones, and they can even hold a pregnancy if in vitro fertilization and the appropriate endocrinological help is given to them. The Mendelian transmission of Fragile X syndrome is X-linked dominant. Boys are typically involved with the phenotypic presentation of Fragile X syndrome. The fragile site is on the long arm of the X, and it occurs typically after at least 200 repeat trinucleotide sequences involving CGG. Trinucleotide sequences have been found in many chromosomes, and often there is some function associated with this. In this particular site, the only function is to produce an abnormality, which is the Fragile X syndrome. Now, the expansion of the CGG, the trinucleotide sequences, occurs during meiosis in the mother, and girls then, who typically do not have the overt phenotypic expression because of lionization, that is, because of random inactivation of one of the X chromosomes, will have anywhere from 50 to 200 repeat sequences and therefore will not have the full phenotypic expression. However, we should be aware that if a boy in a family is diagnosed with Fragile X syndrome and has female siblings, that the siblings may have some degree of decreased intelligence, which would go along with the 50 to 200 repeat CGGs. But again, they're not going to have the physical features of Fragile X, even though this is X-linked dominant. Fragile X, because these people can reproduce, there is no problem with that whatsoever, is the most common cause of inherited mental retardation on a worldwide basis. The presentation of Fragile X syndrome is anywhere from mild to profound mental retardation. These boys have significant dysmorphic features. There are many, but the most prominent ones, the ones that are identifiable in terms of them having Fragile X syndrome, are large ears, a large jaw, and a long face. These are boys with tall stature. They have macroorchidism, which means that they have large testes. Their prognosis is a normal lifespan. There's nothing necessarily that's going to kill them at any early point in time. The Beckwith-Wiedemann syndrome will be diagnosed in the immediate newborn period with classic findings. It is a sporadic genetic syndrome that has to do with abnormal IGF-2 production, and therefore there are abnormal issues related to growth in the fetus and the newborn. The disruption is at the 11p15.5 site and is a classic example of genomic imprinting, which we will discuss in a short while. The findings are that you have a large baby, so microsomia. They typically have very large tongues. We call this macroglossia. And the reason for this, like in the infant of a diabetic mother, is because of hyperinsulinemia. But unlike in the hyperinsulinemia that we see in the infant of a diabetic mother, which is secondary to the mother's glucose problems, diabetes, these mothers don't have diabetes, and therefore for the neonate to have hyperinsulinemia, it has to be due to pancreatic beta cell hyperplasia, which is what happens here. This results in typically profound and sustained hypoglycemia after birth, and is the most important issue that has to be taken care of as soon as possible on an emergent basis. These patients also have abdominal wall defects, anywhere from umbilical hernias to omphalocele, and probably the most characteristic finding that we see at birth and going forward is hemihypertrophy. That is, the left versus the right side of the body are a different size, either partially, maybe an arm, maybe a leg, or the entire side of the half of the body. It is because of the hemihypertrophy that we have a strong association with abdominal tumors, particularly with respect to the development of a Wilms tumor, again, over the first 5 or 6 years of life. And therefore, besides glucose control, which is often difficult, we have to do serial ultrasounds every 6 months, along with serum alpha-fetoprotein evaluations until about the age of 5 to 6 years. Prader-Willi syndrome and Angelman syndrome are the classic examples of genomic imprinting. An imprinted segment of a chromosome is a segment where the genes of that particular chromosomal segment are differentially expressed depending on whether they have been inherited from the mother and the father. So some genes within a segment inherited from the father are silenced, some inherited from the mother are silenced, and the silencing, which is called epigenetic silencing, occurs with methylation onto the genetic material and or with histone modification. That means that in the fetus, with respect to an imprinted segment of the chromosome, there will only be a haplotype copy of genetic material instead of the normal diplet type, because, again, one haplotype of certain genes has been silenced from either the mother or the father. That then is the normal circumstance. The abnormal is the same deletion, irrespective of whether we are talking about the imprinted segment of the mother or the father. The problem causing both Prader-Willi syndrome and Angelman syndrome is a deletion at 15q11 to q13. Now, if the deletion occurs in the paternally derived chromosome, then obviously you will be left with a haplotype copy of the maternally derived genes, and that situation in the fetus produces Prader-Willi. Whereas if the deletion occurs in the egg, that is from the mother's side, you will be left with the haplotype genetic material from the father, and that deletion then produces Angelman syndrome. The findings then of Prader-Willi syndrome are morbid obesity with hyperphagia, that is, inability to control eating. This typically starts in the second year of life, where we see a rapid increase in weight, crossing percentiles, and a description from the mother that the young child just can't stop eating and never seems to be satiated. Now, the first year of life is not like this. In the first year of life, children with Prader-Willi syndrome often have trouble eating. They typically require nasogastric feeds or even the placement of a gastrostomy tube, are slow to gain weight, and have slow growth overall. So the most characteristic findings which we think of in terms of defining Prader-Willi don't occur until the second year of life. These patients will be found to have mild to severe retardation in general, but most are mild to moderate. They will have episodes of binge eating and tremendous weight gain, as stated, small hands and feet and small genitalia. And the bottom line is that the hypothalamic pituitary axis is completely abnormal. There's global hypothalamic pituitary dysfunction. So we not only got a problem with inability to suppress appetite and the eating problems, but we have growth hormone deficiency, we have thyroid deficiency, adrenal deficiency, and often diabetes insipidus. In other words, global endocrine problems, and this all has to be evaluated, and these children are candidates for growth hormone administration. So the other syndrome related to imprinting at chromosome 15 is Angelman syndrome. This time, the deletion at 15q11 to 13 comes from the eggs, from the mother's side. And this gives a classic finding originally shown by Dr. Angelman. These kids have severe mental retardation. They have very little speech, or at most 5 or 6 words. They have sudden paroxysms of inappropriate laughter, and they have a characteristic gait and movement of their upper extremities. Their upper extremities have jerky movements, almost hemiballistic, and they have a wide base ataxic gait so that when you look at them, they look like a puppet on a string. Supportive care in the long run is what is necessary with these children as they get older. Pierre-Robin sequence starts with mandibular hypoplasia. Because of the mandibular hypoplasia, the next thing that happens in sequence in utero is a posterior displacement of the tongue. Because of that, we have abnormal development of the soft palate, which can result in abnormal shapes of the soft palate, bifid uvula, and palatal clefts. The small mandible is known as micrognathia. The displacement of the tongue is called retroglossia. The good news is that when this is diagnosed, even if the patient needs to be at first intubated because of airway obstruction due to the posterior placed tongue, and even if they require then a tracheostomy for the first years of life because of this airway obstruction, we know that jaw growth occurs over the first years of life, and generally at some point the tracheostomy can be taken down as the tongue is displaced anterior again with good jaw development, and the patient then typically has no further airway obstruction. Achondroplasia, and its lesser form, hypochondroplasia, is the skeletal dysplasia that we need to know about for this exam, and it causes what is called short-limbed dwarfism. The limbs are proportional. There are no other abnormalities of the limbs or other disproportions that give us one of the many other types of skeletal dysplasias, which is a very complex subject in pediatrics. This is an autosomal dominant condition and is generally related to older paternal age. As such, with autosomal dominant mutations, particularly in this one, we get almost all cases from a new mutation. The mutation specifically is called FGFR3, and it is found at 4p16.3. The findings are extreme short stature because of early fusion of the capital femoral epiphyses. Therefore, the problem is due to proximal femoral shortening. And that means when we look at the upper to lower segment ratio in these kids, it is increased because the denominator, the lower segment, is significantly decreased. And so the ratio of the normal upper part of the body to the abnormal lower part of the body becomes significantly greater than 1. In the full form, the achondroplasia, these kids have large occipital frontal head circumferences. They often have a hydrocephalus associated with this if there's a small foramen magnum causing obstruction, but many of them do not have that. In addition to the large cranial vault, what they do have is a short cranial base, and early in life, this may produce the major morbidity with this, and that is compression at the base of the skull onto the neck, and if this happens, then it has to be recognized quickly and surgery has to be performed. Because of the unusual shape of the head, the large head, there's a prominent forehead, so we have significant craniofacial abnormalities, which means one of the problems in early childhood because of this is an abnormal eustachian tube, which means repeated ear infections and conductive hearing loss. It is difficult at first when these kids start to learn how to walk, typically at 1 year of age, for them to be able to walk because of the fact that they have to balance a large head as they get up and start walking. Because of this, walking is usually delayed, often until 18 months or even longer, until they figure out that they have to develop a lumbar lordosis to shift their center of gravity forward to be able to balance themselves. And so as they go forward in life, again, they have a significant lumbar lordosis, but in addition to that, they have a number of different types of vertebral defects. And as a result of these, going ahead into adulthood, this represents the major morbidity in older children, adolescents, and adults. And intelligence is normal. Marfan syndrome is autosomal dominant with wide variability due to an abnormality in the fibrillin gene, giving us abnormal collagen formation. These are tall children. Again, this is most commonly diagnosed for the first time in later childhood to adolescence. They have long limbs and long fingers. The fingers have a spider-like appearance, fingers and toes for that matter, and this is called arachnodactyly. As we talked about before with Klinefelter syndrome in the description of the Marfan phenotype, these children will have an upper to lower segment ratio that is less than 1 because, once again, the primary reason why they are so tall is because of the lower extremities being so long. The major problem with Marfan syndrome, and one of course, the distinguishing features from Klinefelter, in addition to not finding any of the features of Klinefelter syndrome, is that they have joint laxity, and so abnormalities of their joints, particularly abnormalities in the thoracic area, causing kyphoscoliosis. Sometimes this may be quite severe. You can see in the picture one of the more severe types of Marfan syndrome, the severe arachnodactyly. This patient would probably be expected to have severe joint problems, skeletal problems, and perhaps be moderately to severely disabled as well. Other problems which we see in Marfan syndrome is a defect in the suspensory ligament causing upward lens subluxation, The major cause of death, the major morbidity, is vascular complications, particularly with respect to dilatation of the ascending aorta. The most common problem, therefore, is aortic regurgitation, secondarily mitral valve prolapse, and any patient, because of this, may have a dissecting aneurysm, and this, of course, has to be followed very, very, very carefully. The previously 10 types of Ehlers-Danlos syndrome have now recently been shaved down to 6. Type 1 is the most common. Presentation, again, is autosomal dominant. They have the same general findings as the Marfan syndrome, except they do not have a Marfanoid appearance. In fact, the major phenotype of Ehlers-Danlos syndrome among all 6 types is shorter stature, or at best, normal stature. They characteristically have droopy ears. They have other facial problems, dysmorphic features. They may have blue sclera. They also have ectopia lentis. But the major problem is not only joint hyperlaxity like we see in Marfan syndrome, but the distinguishing feature which you can see in the bottom picture, which is hyperextensible skin that is very fragile. It bleeds easily, it scars easily. You can even have bleeding from the skin into contiguous joint areas, further limitation and problems with the joint because of this secondarily. And once again, cardiac is the major morbidity. Mitral valve prolapse and tricuspid valve prolapse. Other defects, sometimes an ASD is seen, but again, because of aortic root dilatation, we may have a sudden rupture of the aorta, and just as in Marfan syndrome, this needs to be followed carefully. Next, we'll talk about some of the more common teratogenic syndromes. The most common is fetal alcohol syndrome. This is the most common teratogen. The problem with diagnosing this is we may not always know for certain that the mother has been a heavy drinker during pregnancy due to a number of different reasons. This is clinically important because then the diagnosis comes down to recognizing the classic features of an infant or a young child with fetal alcohol syndrome. Now, alcohol during pregnancy causes problems with growth. Because these mothers are going to be drinking prior to getting pregnant, the infant will have the early onset symmetric intrauterine growth restriction. So in addition to having a decrease in their length and their weight, they will also have a decrease in brain growth, and therefore the head circumference will be low. They may have mental retardation. It may be mild to severe, but certainly all kids have some degrees of behavioral anomalies, and at the higher levels of alcohol consumption may even have neurological defects as well. The alcohol during pregnancy affects the forebrain primarily, and the forebrain development affects mid-face development, and so we classically have findings of mid-face dysmorphism, such as maxillary hypoplasia, smooth philtrum, thin and indistinct upper lip, small eyes, and the major morbidity associated with this is cardiac anomalies. VSD is the number one. Secondarily, we may have skeletal abnormalities, particularly joint abnormalities of any kind. Therefore, we have to, again, be able to put all these things together and come up with the possibility of how the way the baby looks and the findings that are present in terms of most likely fitting fetal alcohol syndrome. Now, if we have evidence, of course, that the mother drank during pregnancy, then the diagnosis becomes easier. Also, after birth, these kids have low postnatal growth in height and also slow postnatal growth in terms of brain growth, and therefore they remain relatively microcephalic, or at least the brain and the head circumference have a relatively slow increase in size. We used to think that there was a one-to-one relationship between number of drinks during pregnancy and specific outcomes. We now know that this is not the case. In fact, around the world, the most common presentation of drinking during pregnancy for the development of fetal alcohol syndrome is weekend binge drinking. And we now know that the main thing that we can say is that while the most severe drinking in the long run results in the worst prognosis, there's not necessarily this one-to-one ratio. And the best advice that we can give mothers then when they ask if they can have a drink every once in a while during pregnancy is no. Fetal hydantoin syndrome, to some extent now, we recognize findings with respect to many anticonvulsants, and sometimes there are small differences that will allow one to think specifically of the teratogenic syndrome of one versus the other. There's no dose-response relationship demonstrated with this, and so any amount can produce any types of symptoms. The most common findings are listed here. We have growth deficiency, borderline to mild mental retardation, a number of different types of dysmorphic facial features, a short neck, abnormal palmar crease, and two findings which classically go along with the fetal hydantoin syndrome, and that is hirsutism, that is hair on various parts of the body in an infant and a young child, which certainly is not common, and a Cupid's bow lips, that is lips that look like a bow from which one would shoot an arrow. The valproate syndrome produces similar findings, but slightly different. Again, there's mid-facial findings, specifically mid-face hypoplasia, a high incidence of cleft lip, high incidence of cardiac defects, long, thin fingers and toes with convex nails, and here, the big one you want to remember is the high incidence of meningomyelocele. Again, these are sometimes very difficult diagnoses to make unless you know specifically the drug that the mother has taken during pregnancy. If there's any question at all, then a geneticist dysmorphologist is of invaluable help in terms of making these specific diagnoses. Retinoic acid embryopathy specifically has to do with taking of the drug isotretinoin or Accutane related to the timing of conception and thereafter. Again, listed are the most common findings that allow us to feel that this is the diagnosis. Very prominent bilateral microtia or anotia, that is the undevelopment to absence of external ear features. On the same side, facial nerve paralysis. A high incidence of conotruncal malformations like truncus arteriosus, tetralogy of Fallot, transposition of the great arteries. Mild to severe central nervous system malformations of various forms. These are the major findings, and obviously this can result in severe disability. We find that in terms of taking isotretinoin, there are no problems with respect to the retinoic acid embryopathy if the drug is stopped prior to the 15th postmenstrual day. Therefore, the current recommendations for any female using isotretinoin is careful pregnancy screening at the start, use of definitive methods of birth control to not get pregnant during the time of the use of isotretinoin, the additional use of a backup method of birth control, and counseling regarding the teratogenicity at the start of the administration of the drug. Thus far, we have talked in terms of sequences only about the Pierre-Robin sequence. The only other one that we need to talk about is the Potter sequence. Many years ago, we've gone from calling this Potter syndrome to now Potter sequence. The problem here is that the developing fetus has a major renal anomaly. Keep in mind, it's not always renal agenesis, lack of kidneys. It can be some severe form of renal dysgenesis, like infantile polycystic kidney disease or severe obstructive uropathy. But it typically occurs prior to 31 days gestation, so that there is a significant decrease in fetal urine output, which then in sequence leads to a certain degree of oligohydramnios, which leads to various deformations and fetal compression, and in the worst cases we may have pulmonary hypoplasia, which can be a cause of death if the lungs and airways are so hypoplastic that no amount of oxygen and ventilation can relieve hypoxemia, hypercarbia, and acidosis. So the findings may be pulmonary hypoplasia, and this is a strong suggestion in conjunction with oligohydramnios, therefore, that this is indeed the Potter sequence. The way that these babies look, the dysmorphic features of the face, are specifically called the Potter's facies. And this is easily seen on a side view where we have flattening of the midface, we have hypertelorism, epicanthal folds, low set, compressed ears against the side of the head, compressed flat nose, all again due to the effect of the oligohydramnios, and we can have limb anomalies, which are deformations, like a club foot or like congenital hip dysplasia, again due to the oligohydramnios. The cause of death, again, is severe pulmonary hypoplasia. Babies who have little or significantly less pulmonary hypoplasia can be treated with oxygen and ventilation, and over the first months to years of life, airways can branch, more lung development occurs, and eventually the baby who may need to have a tracheostomy at first may be able to have that tracheostomy taken down in time. Finally, the two other associations that we want to mention, in addition to the WAGR association, the WAGR, which we talked about. First is the factorial association, and this is the random production of at least any two of the listed items that we see here. So V stands for any one of a number of vertebral defects. A stands for anal atresia, which is imperforate anus. C is any cardiac defect. T, tracheoesophageal fistula, with E, possible esophageal atresia. We can have one or the other or both. R, any one of a number of renal defects. And L, limb defects, primarily radial defects, as you can see in the picture. So once again, put any two of those together and you have the factorial association. On your exam, given the possibility of a question involving anal atresia, they might simply ask you then which of the following may occur with this, and you would of course be looking for the only other indication listed of being part of the factorial association. And finally, the charge association. This is the same idea. Put any two of these together and you have the charge association. The C in this case stands for coloboma. H, any heart defects such as tetralogy FLO. A, this time the word atresia has to come first to get the A in there, and this time it's choanal atresia or atresia choanae, which involves obstruction of one or both nares. R is retardation of growth and or development. G is general hypoplasia or abnormalities, essentially in males. And E are external ear anomalies, as we see in this picture, and or sensorineural hearing loss.